All right. And so I appreciate the opportunity to talk here. Sorry, I can't be there. I just have another presentation to give in Florida later today. No disclosures relevant to this talk. So historically, if a child comes in like this with a growth arrest on the left side, a little bit of deformity, the reflex treatment is to do external fixator-based treatment. You can correct the varus acutely by putting the pins in. You can also correct any sagittal plane issues by putting in the pin angulated to each other. And when you put in the straight bar, you straighten out the sagittal plane. This gives a fairly reasonable result. At 4 months, this kid had pretty good healing and reasonable alignment. I wish I didn't have that varus. But things have kind of changed recently. These magnetic nails have finally given us an internal option that's very reliable. And so nowadays, if a 12-year-old comes in and has this significant varus deformity and also has a substantial shortening because of their Schmidt metaphyseal dysplasia, then I might just give them a little bit of length while putting in one of these nails to correct the varus. And in doing so, can get them to the point where they get a little bit extra length. They are partial weight bearing for a while, so that is a disadvantage, but I can get them the full weight bearing by about 3 months in this kid with a pretty good result. If it's an antegrade nail, it's usually a little bit easier. They don't get as much irritation at their knee. And so these go quite easily. They've been surprising how good their motion is. This kid at 12 weeks had that kind of motion actively. And that's just not something I've ever seen with an external fixator. So these have really changed what we can do in terms of there's a lot less pain, there's better mobility of the joints, and we don't have to deal with pin tract infection. So this has really changed the field of limb lengthening, but we always have to remember about the joints. We're lengthening the bone, the muscles get tight, and the joints are at risk. And so when you do external fixator-based lengthening, like in someone with congenital femoral deficiency here, you can see there's a hinge going across the knee to protect the knee. And if these are well placed, then they can have fairly good motion with these on. And we just feel a lot more assured that we have protection there. Even in this kid who was undergoing this lengthening and had some posterior subluxation of their tibia, despite that protective hinge being there, you can take them to the OR and you can correct them acutely and keep that hinge on to keep them in place and feel some confidence that they're going to have a reasonable amount of motion in the future. So this is him a year out with good motion of his knee. You don't have that option with the internal lengthening nails. And so you have to really be aggressive about your physical therapy. You have to consider bracing and use it pretty liberally. And you have to be very ready to stop or reverse your lengthening. One of the advantages of these new nails is they can go in reverse. So if you've gotten too tight at your joints and you don't feel like you can win with just stopping and aggressive therapy and bracing, then you can actually shorten them acutely, which is a really good option, but something that you have to be considering. There are ways to protect the ankle. This is not my case, but this is a patient that I followed for a colleague. And so there are ways to protect the ankle joint. You can argue that has some issues in of itself, leaving that screw in for several months, but they do seem to have reasonable motion after they come out. There's limitations in terms of what you can do when you're lengthening with the nail. The femur has a bow, and these nails have to be straight. They cannot have a bow because of their lengthening gears and design. So if you have a femoral bow, you either have to make your osteotomy at the midshaft or you have to put in a short nail. And that depends on what you're trying to achieve in your surgery, but you have to plan for that in advance. If you're, in terms of where you make your osteotomy, you want 5 millimeters of the thicker portion of the nail to cross the osteotomy when it's all over. You have a 30 millimeter short telescoping section, and then you have the amount you lengthen. So you have to add all that up, and your osteotomy can't be any closer to the distal end than that. So if you're lengthening by 5 centimeters, you need 13 centimeters of nail in the distal segment. Otherwise, when you're done lengthening, you just won't have enough stability. You have to pay a lot of attention when you're lengthening the femur because you're lengthening in the anatomic axis, but what you really care about is what happens to your mechanical axis. And so because of that, you do develop some mild valgus with femoral lengthening. So if you're starting off with valgus, then you got to think about going distally or doing something else. In the tibia, you have to be very careful about valgus and procurvatum. The tibia has all of its musculature posterior and lateral, as well as the fibula, and all those restraints are trying to drag your bone into valgus procurvatum the whole time. And so you have to be very careful about that. In terms of techniques to do some deformity correction when putting in nails, you can do fixator assisted, where you maybe put some pins that are offset in the beginning, and then you line them up, you put on an X-fix bar temporarily, and then you can put in your nail, and then when everything's done, you can take the X-fix off. It's a common technique. This is a patient with Blount disease, and classically Blount has always been treated with hexapod external fixation for most people in today's day and age, and that's still my go-to treatment. But on occasion, I feel like there's certain patients that just can't tolerate it, and if they do not have procurvatum, like this patient has no procurvatum on that sagittal view, then you have and if their osteotomy site, like where you think their deformity is reasonably distal, then you have the option of a nail. It's really challenging, but you can do it. If they have some procurvatum, the nail almost always sends them into more procurvatum when you put it down, and it becomes very challenging. But with this patient, I was able to put some external fixator pins proximally to try and hold to prevent any procurvatum. I took out a little wedge of bone. You could say I put some half pins here on the sagittal view, and they're serving as blocking screws as well. They're preventing that path of the reaming from going too posterior. And then liberal use of blocking screws afterwards. You basically want to make your canal narrow in that proximal segment by putting screws around it. And so with all that, we got reasonable correction. It wasn't 100%, and that he was in a little bit of varus. I was somewhat praying that the valgus that normally gets created would help me in this case, but it didn't. I got my length, but I didn't get the correction of the valgus, so I did have to take him back to the OR. I actually mounted a hexapod frame around his nail, took off his nail, corrected him, and then put a new nail in. So it's a lot of work to treat these patients this way, but you avoid a frame on a very obese person. And so there's some benefits to it. So this is in 3 weeks out, and you can see in that second to the left image that the femoral condyles are orthogonal to the nail. So we finally got him out of that varus. And on the views to the right, you can see he has some posterior tibial slope. We've created some that we didn't want, but we didn't put him into a position where he couldn't fully straighten his knee. One important question in children is, what about the growth plates? Can you put nails through these growth plates? For the proximal femur, the answer that most people will give you is that after age 8, both males and females, you can put a nail through the greater troch. So you can do a troch entry nail, and there are troch entry lengthening nails. This is some anatomic data that we put up a few years ago that shows that by about age 8, you've pretty much established your mature size of your greater trochanter. So in theory, it's not very much of a growth issue. In terms of the distal femoral physis, we've done a lot of work here with sheep to study whether it's safe. And our data has suggested that if you violate 7% or less of the cross-sectional area of the growth plate with your nail, then you are safe in the distal femur. And it turns out that because of the relative size of the isthmus versus the distal femur, it's very hard to need a nail bigger than 7%. Really, most of the times you're much lower than that. So that suggests some safety data. Some of my colleagues in Mongolia have done this for their trauma cases. And so because of the resources that they have, they don't necessarily have the other treatments that we would offer for this. And they would put in a retrograde nail, as they did here. And upon follow-up, you can see that the relationship of the growth plate to the nail has changed. The nail is essentially drifted up the bone. They take that out. And at 21 months, they don't have any limb length discrepancy in this patient. So it kind of demonstrates that there is some resilience to that distal femur. And we've done a whole case series of theirs showing no growth arrests. The proximal tibia is totally different because the entry of the nail is so anterior, and we know that growth plates don't like it when you violate them eccentrically. They're much more tolerant of being violated centrally. And so in the proximal tibia, you have to do that. And so there is some risk of developing recurvatum if you do this type of an approach. This study did not find any cases, although their patients were pretty close to skeletal maturity. I have had one patient where I placed a nail that came out fairly anterior through an open growth plate. And I watched them. And a year and a half later, I'm looking at recurvatum of that proximal tibia. So I've created a growth arrest proximally, or at least growth inhibition enough that I developed this deformity, and that's something that has to be treated in the future, unfortunately. So overall, I do think that internal lengthening is the future of limb lengthening. People around the country are doing everything they can to avoid external fixators. Certainly, external fixators still have a huge role. You have to remember that it is still lengthening surgery. You must protect the joints. And there are some limitations. The canal limits you both in the femur and in the tibia. Any procurvatum in the tibia really should give you pause on whether you really want to try a nail there. And then for the growth plates, it seems like the main limitation is the proximal tibia. The femur, you can kind of work around it in reasonably aged children. Thank you very much.